Afternoon, everybody. You're very welcome to Digital Dispatches. We are now on our 20th edition, believe it or not. So Happy New Year, you're all very welcome. Today we have an update from the Encompass team. So we have Dr. Dermot Hughes, Dr. Veronica Devlin and Teresa O'Donnell here to talk to us today, just to give us a bit of an update on progress, what's in front of us, and an update on what's happening in the social work and social care arena. As usual, we'll be recording this, so please let colleagues that aren't available today just know that that will be available later. And we will take questions as usual in the chat. So with no further ado, I'll hand over to Dermot.
Hello, everybody, and thanks for joining us today at lunchtime. I'll be speaking partly, but my first task is to introduce my colleagues who will be leading the discussion. First of all, I'll start with Teresa O'Donnell. Teresa is from the Northern Trust, and she's a social worker grounded in the service who is passionate about delivering better care for service users and improving the working day and working life of social workers. And we hope to show how we can do this through the EPIC platform and the Encompass implementation. Teresa would freely admit that she's not an IT specialist, and neither am I. Our passion is about making care better for patients and service users, and about making jobs more deliverable for professionals. We're also joined by Veronica Devlin, who's a qualified GP and a qualified ED specialist. In her background, she has done major pieces of transformation work. And her most recent piece of what I regarded as transformation work was Programme Director in the Manchester Foundation Trust EPIC implementation, which, for those that don't know, is a large conurbation of 1.8 million, I believe, and 12 major acute hospitals. Veronica brings a wealth of knowledge, experience, and know-how to our programme. She brings that with a depth of knowledge in patient care and patient care transformation. So she has a multitude of skills, and she has a family background from Northern Ireland, so that's also a benefit. For those that don't know me, I'm Dermot Hughes. I was the medical director of the Western Trust previously, and I'm standing in lieu of the CMO. My probably more pertinent background was I was the medical director of the Cancer Network, and in that work, our role was really to standardise care along best practice guidance along with patients and service users, and to make sure there was a standardised process for cancer care across Northern Ireland. And the EPIC implementation replicates that work for all aspects of acute care and social care across Northern Ireland. So with that introduction, I will now hand over to Veronica to lead the first part of the discussion.
Thanks, Dermot. Paul, I can't see the slides moving on. I think we're still on the front sheet. So if you'd like to scroll through for us, please.
Okay. Partly it's stopped here. Give me 3 seconds, please. I'll try and restart.
So while we're dealing with the technical issues, I'll just talk a bit in general about Encompass. So most of you will probably have heard something about the Encompass programme. Fundamentally, it's a transformation programme which has an EPIC electronic patient record at its heart. But fundamentally, it's about changing how everyone in health and social care really works to share information together, and how information is available to both staff across all of health and social care and also to patients. There are some extremely exciting and innovative aspects of this electronic patient record which will really engage patients in their care in a way that they've never had access to before. So we'll talk a bit more about that later on. So it's about change. It's about changing how clinical and operational staff work together. It's about changing how we share information between and across disciplines, organisations, and with patients. So lots of new things to learn for everyone, and lots of opportunities, because the go live of these systems is really only the start. It opens up lots of opportunities for improvements in care and improvements in patient and service user safety and improved access. So can we move on to slide 6, please? So this is a really very high level timeline. We've completed the pre-work in 2021, and throughout 2022, it was about looking at workflows and configuration and build. And the unique thing about the EPIC system is that staff right across health and social care have been engaged in helping to define and design a bespoke system for Northern Ireland. So it's based on a foundation system that's available throughout the UK, and it's developed by each organisation who take it on board and develop it for their standards and for their context. And that makes it's not an off-the-shelf product that you just plug in. This is something that people have been working on for a number of years to make sure that it is ready and fit for the Northern Ireland context. So we're now moving into the user and system readiness phase. So build is almost complete. And this is really about making sure that staff, the organisations, and to a certain extent patients and service users are ready to accept and use this system to its best capability. So at the minute, we're going through a testing phase. So making sure that all of the bits work independently, then all of the bits will work together, and that all of the bits will work as a single system. So that process will continue throughout 2023 up to our first go live date, which will be South Eastern Trust, and that will be in autumn time of 2023. And then subsequent to that, as you can see, there's a sequence of go live events which will happen roughly 6 months apart, taking us into mid-2025. The system will then be live in all of the trusts across Northern Ireland, and that after that phase, we start to look at optimisation. So looking at improving access and functionality in the system as we have it, and looking at making sure that any additional developments that have happened in the interim during the go live period throughout healthcare can be incorporated. And the other unique thing about this programme is we will have a team of health and social care staff who are effectively the builders for this system, and who will remain with the organisation and remain to further develop the system as we go through beyond 2025. So that the go live events themselves, people get very focused on them. They're very exciting, they're very important, but actually it's really just the beginning of a 10-year journey effectively, where we can continuously improve how we share information and how we use that information to the benefit of patients and service users and staff in Northern Ireland. So just coming on to some of the benefits. For staff, it will mean that they can spend more time on what's important. So looking at the recent BMA survey that took place really gave some insight into the frustration that clinical staff have with access to existing digital records and digital records that are not joined up. So this will be a unified system. It will replace paper records. Staff will spend less time chasing them, trying to figure out what people have written, and there'll be less repetition. So there'll be a single version of truth for a patient's history and all of their interactions with health and social care, which will be accessible. That will free up time to do the really important stuff, which is looking after patients and service users, and it will support much more quick decision making. It will support shared decision making, and it'll help us standardise care, because some of the standardisation will be built in through the build of the system, but it will mean that we can share best practice much more quickly and implement best practice pathways much more quickly and effectively, and we'll be able to audit them more clearly as well. And from the patient and service user point of view, they won't have to tell their story 10 times every time they have an interaction with a member of staff. They can feel secure that the evidence-based standards have been employed to actually devise the system that's supporting them, and that practice is being looked at and monitored. And they'll have greater ownership of their health and social care journey. So the patient portal that comes with this had the capability not just to allow patients and service users to manage their appointment schedule, it can also help them with access to self-care pathways, information from their clinical teams, and support when they need it. It will effectively be part of their record in their pocket. From the point of view of safety for patients, we can be sure that if the information is captured once accurately, it exists throughout the care record. So things like alerts for allergies and consistency of medication dosing from a patient point of view will make it much better for them in terms of quality of care. Can we move on, please?
Sorry, everybody. Computer is really struggling today.
Yeah.
Dermot, we're on.
I think I'm coming in next night. I'm going to talk about meeting the needs of the programme. As many people may be aware, the programme has been in genesis for some time, and because of COVID and a few other reasons, the programme timeline has been increased to 13 and a half years. So some of the pressures on the programme was shortage of staff, shortage of funding for trust staff, and ability to recruit people to the technical roles with appropriate knowledge and skills. So as part of this process, the team went into bilateral discussions with the Department of Health and Department of Finance, and happily the addendum to the programme has been signed off just before Christmas on the 16th of December, which was a huge vote of confidence in the programme. What it means is that we will have appropriate additional resources for trusts for implementation, and that's in the background of a 10% vacancy rate in all trusts, and a vacancy rate in all trusts who are probably currently operating at 115 to 120% activity levels. So while we're doing a difficult task, we're doing it in difficult times, and the addendum is additional resource helping us to put additional resources in place. The programme, I said, is 13 and a half years long, and we will have 73% of the build team available for the life of the programme. This means that we're not simply doing a delivery of an implementation and walking away. It means that the life of the programme will have a large optimization process and an ongoing mechanism to improve services in Northern Ireland. It's very important that we see this as a generational change instead of a one-stop shop, which we do an implementation, say in the Southeastern Trust of October 2023 and sequentially across Northern Ireland. That this is a major change about how we work across Northern Ireland and how we collate data across Northern Ireland. There will be benefits, obviously, for efficiency and effectiveness by doing things the same way, and there will be benefits in terms of safety and quality. The underlying premise for this process is to empower patients so that they have a patient portal and have access to their own information, but it's also to provide an infrastructure that would allow transformation of care in Northern Ireland. So if we take examples of elective surgery, this will only happen if we have the same pathways everywhere with the same platform managing patients. Okay, so are you struggling with the slides, Paul, still?
Yes, I am indeed. We're trying to sort it, please.
Don't worry. The next piece is about governance, and I'll explain the governance. Governance is often seen as Big Brother looking over you to see what went wrong. The governance in this programme is to support people making the right decisions from the ground floor up, and I'll explain that. We have e-design groups and focus design groups. This is slide 11, Paul, what we're doing there is deciding how we deliver care and social care and healthcare across Northern Ireland in the same way in all 5 trusts. That's based on the EPIC UK model platform, which has nice guidance embedded into it. So we're applying best practice across Northern Ireland, and the governance structure is there to support those making the decisions. So if a group of paediatricians make a decision to do a thing a certain way, that flows up through our governance structure so that they have support. If we decide to do social care in a different way, and this is a very pertinent topic, we've gone through the process of discussing children's social care and how we can best do that on the EPIC platform. But it very quickly became obvious that by doing it on the EPIC platform, we could apply the uni-tuni outcomes in a more efficient and effective way. But the teams deciding that needed governance support to allow that to happen. So we could plug in the next layers of governance across the trust and into the Department of Health to ensure that that was not only the right thing to do, but it was the supported right thing to do. So the governance process around this is making sure the right thing is done for patients and clients and the right decisions are supported and known about across the programme. We also have external scrutiny to the programme, so we have internal audit within the Department of Health. We're employing Deloitte to do a health check to benchmark us against work elsewhere and to take a critical look at our benefits realisation. We feel that we can do better than that, and we feel that the original full business case was not sufficiently comprehensive. The programme has also changed. It has expanded in its nature. It's now bringing in on all of cancer services and will outreach to not simply trust community services, but will also have to outreach to private sector community services following the recommendations within the neurology inquiry. Currently, the NICR outreaches to private sector providers, but that's on the basis of COVID legislation. We need to do this on the basis of more permanent legislation. But it means that the programme will be truly comprehensive. When we think of private sector provision, we think in terms of Knightsbridge or elective care, but actually the largest provider of private sector care is private nursing homes, who are a critical interface with our social care staff. And the system, as we currently now know, won't function unless all aspects of the programme, all aspects of care function coherently. And we perceive the ability to outreach into nursing care and private nursing care as critical for the future of delivery of care across Northern Ireland. So the governance of the programme is within how we deliver things, it's how we decide things, and it's how we work across the primary care, secondary care, and private care. Okay, I'll now move on to the next section. I'm going to bring Teresa in, who's been quietly waiting to talk to us about the journey social care has been on. So Teresa, please, over to you. And this is slide 12, Paul.
Lovely. Thanks very much, Dermot, and indeed to Veronica and Linda for the invitation today and giving me the opportunity to tell you a little bit about some of the steps we've been taking in social care alongside EPIC. As most of you probably will know, Northern Ireland is the very first UK country and only the second country worldwide to integrate their community care and social care systems with health. So for us, this has been very much, I think Dermot has alluded to this and Veronica, very much the start of a journey. And it's therefore about creating something that is bespoke and truly unique. I would have to say it has not been without its challenges. It's a major transformational programme, but we're working very closely with EPIC and Encompass along this journey. I'm hoping today that this very short presentation will act as a springboard for discussion and questions at the end. So before I tell you a little bit more, I just wanted to provide you a very brief picture of social work and social care, and indeed what Encompass met when they started to work with us here in Northern Ireland. So just to let you know, social workers and social care workers are employed in several areas within the trusts. Children and young people, older people, mental health services for adults and children, physical and sensory disability, residential and daycare, supported living, and work indeed in our hospitals and our GP federations. So you can see with that, the spread of our workforce is extremely broad. And again, we can't turn the radio on or open a paper without knowing that there are pressures to varying degrees in terms of a rising demand for social work and social care services, particularly around complexity and indeed acuity of need. Just as an example, children placed on our child protection register last year increased by something around 20% to 3,000 children. And we also had the highest number of looked after children since the Children's Order came in 95. Again, as many of you might know, Northern Ireland has a population with a significant proportion adversely affected by high levels of trauma, deprivation and division. And the rollout of the Mental Capacity Act has also placed significant demands upon trusts, which required the development of new teams and protocols. Further to that, if we look at the projections in the age composition of the population, we can see that the numbers indicate that numbers aged 65 plus will increase by about 28% to over 400,000 by 2031. And again, this places further pressure on an already pressurised system. And then finally, when we look at our social workforce, we can see regionally that we have nearly 11,000 staff. That's made up of social workers, managers, care managers, support workers and admin staff. And again, when we look at the data that was collected as part of the social work review in 22, there were indications that there are significant workforce deficits in all of the trusts. So that's very much really a picture of where we're at. Paul, if I could have the next slide, please. If we remain having some problems, this slide was really around paper, and it was to do with our paperwork and the challenges and that brought to us. So essentially, within our trust, we are currently using some 5 key systems. They're often slow, they're clunky, outdated, and often don't speak to one another. There we are. There we go. I do like this cartoon. Do you remember when all we had to do was help people? And I think many of us can probably remember that. And I suppose the question is today, and with Encompass, does our current systems help or hinder us in that mission, which is to help people, support people and to safeguard people? So going back to what I was saying, in terms of our systems, 5 key systems, clunky, don't speak to each other, paper files, and what I would describe as a myriad of other systems, add-ons that have been sort of individually created over the years to provide some easement to the management of service user records. So a social worker, sometimes at a critical or urgent time, is faced with having to access information across different systems and paper files, probably around a time when they're needing to make an urgent prompt decision about safeguarding. If we look at older people's services, social workers indeed can expect to complete multiple forms when completing an assessment and care plan, and then making a request for commission services. So across a large caseload, this results in a huge amount of paperwork and duplication, time and effort. And often the person, the social worker is trying to help, is then faced with having to negotiate their way through that paperwork when coping with, for example, poor eyesight, for example, or limited manual dexterity. The picture too is similar within children's. When a child or young person is taken into care, again, a social worker can expect to complete up to 20 separate forms as part of that process. And this is at a time when the social worker wants to spend time with that child or young person at this most vulnerable time for them. So the concept for, and we've heard this, building once for Northern Ireland is both timely and desired. The benefits of Encompass, which I would summarise as greater capacity equals greater satisfaction, will bring significant gains for social work staff and to those who use our services. Again, as Veronica has referenced earlier, all the records will be in one place. They'll be accessible via just a few clicks, and social workers can be freed up to spend more of their time in supporting and actually looking after the needs of people. So Encompass therefore shone a very bright light on our practice and asked us a very clear question. What is it that you want to build for us? Paul, if I could have the next final slide, please. So to explain how this process has been undertaken, and again, Dermot referenced children's here, just want to take you through some of the steps we've taken within children's and around the what's called the Unicini assessment framework, which stands for Understanding the Needs of Children in Northern Ireland. Discussion about this framework has been going on for some considerable time. There was definitely a desire for it to be more streamlined, less bureaucratic and more user-friendly. And the arrival of Encompass really prompted and facilitated that work to start in a time-limited way. So what we did was we started with a regional 3-day workshop that was attended by all of our trusts, our colleagues in SPPG in the department, along with EPIC and Encompass staff. We then followed this with 4 specialist work groups, which essentially looked at all of the workflows and content, but through the lens of Encompass. Social workers and managers brought their considerable expertise and experience to bear, and working within the Encompass and trust governance structures were empowered or felt able to make decisions about improving and making changes to this framework. So a group of about 25 to 30 subject matter experts continue to be engaged in the process, and the chairs of those work groups ensure that this work is being progressed at pace. So there is a great sense of momentum to achieve that positive change. As we speak, new documents have been created and are being built out. Workflow demos are ready and for viewing and signing off. And I just learned today that we're going to be looking at that as early as next week. And we're looking at signing those off, and this will all be in time for sets go live later this year. Some level of testing, I mean, this is all about how have staff experienced this, how have our service users or the people who use our services. So some level of testing has been completed. There has been positive indications from staff about the considerable time savings in the reduced paperwork, as well as from our service users, who are also reporting positively about the simplified information. And I'm sure when we look at the demos, we will be able to see further increased efficiencies. I just want to finish off by saying something about what I would consider as maybe an unintended consequence of our work with Encompass. And that has been perhaps the intra-trust working, as well as our partnership working with the SPPG, the department, all of which I feel has been very much strengthened. There is a commonality and a shared purpose to achieve the similar goals, while also keeping an eye to our statutory functions and due diligence. A similar method is now underway in adult services, and we are currently in the process of reviewing those workflows and documentation in much the same way. So in closing, I would just like to stress that Encompass has given us a firm footing on which to work in the future. It certainly is a journey, but as we continue to configure and adapt Encompass to hopefully meet our needs in social work and social care. Thanks everyone, and back to Dermot.
Yeah, thanks very much for that. And I managed to miss one of my slides, but it's probably just as well because I'm going to talk about two things together. It's about taking the plunge and looking ahead. First of all, taking the plunge, I'm going to really spend some time thanking the South Eastern Trust and the leadership of Roisin Coulter, her team, Helen, Naomi, Sean, Julia, David Wilson, Pippa, Angela Reid, Morris, and I'm sure I've forgotten a few more. They're obviously going to be the first trust to undergo implementation. They will be the first trust in Northern Ireland, and everybody else in Northern Ireland will benefit from this piece of work. That's going to happen in October, say, of this year. We still have to agree the exact date, which will be their choice and choosing, and which will align with their clinical needs. To date, they have to recruit super users, and the latest figure is that in the mouth of Christmas, in the mouth of all the problems that they're having in terms of clinical services, or that everybody's having, they have recruited over 950 volunteers to be super users, which is an absolutely astounding figure. We would like to help them with a team of 1,500, and that will require people coming from other trusts on a peripatetic basis to help with implementation. This will enable learning to be spread across Northern Ireland and to build a team of expert users across the patch, working on the pioneering processes within the South Eastern Trust. Going first is perhaps the bravest thing to do in Northern Ireland, and going first has to be recognised, requires strong leadership, strong focus, and the ability to do multiple difficult things at the same time. And clearly the South Eastern Trust have this, and I just want to pay sort of respect and thanks to Roisin's leadership. We reached this place after going to the UGM in Epic in Wisconsin, and some people were on that who are on this call were at that meeting. And Roisin certainly challenged us to have a can-do approach, have an approach that when you're implementing it, good is good enough. And I think the start is really important. Once it will deliver the outcomes. So I should planning for the future. The changes that have happened in the last year have been really quite remarkable. We've heard the story of social care, and that's been really, really rewarding, and it will ensure that social care gets the focus it needs, because it's an under-resourced critical part of our service. Cancer services, systemic anti-cancer therapies and haematology have come on and are going to go through a parallel implementation of an EPIC platform, and that means absolutely every aspect of care in Northern Ireland, including the private sector, will be hosted on the EPIC platform. In essence, everything in Northern Ireland, with the exception of the radiology services, which is going for a repeat of the really high functioning sector system, and the laboratory services, which are going through Clinicis, but will link with the EPIC system, will be on the EPIC platform, which is cradle to grave. This will have huge benefits in terms of how we deliver services, but it will have huge benefits in terms of how we commission services and how we link with universities, do research about services. So we've moved from point A to point B, and we've moved from a planning to get this done to in the processes of doing it. We're having meetings in the next couple of weeks to plan the actual processes of doing it in the South Eastern Trust. And that will be the first implementation, but it will be the first opportunity for all of us to learn. Okay, I'll now pass you on to Veronica.
Yeah, so I just wanted to go back one and talk a bit about training and super users, because we're at the phase in the programme now where the rubber really hits the road, and we're we're at the stage where people need to understand what's going to be required and available to them to equip them to use the system, particularly SET for the first go live. So training is the single most important predictor of outcome, if you like, in terms of how well people interact with the system, how comfortable they feel with using it, and how well it's adopted. And so it's really important to get training right. And it's not as simple as switch it on and someone stands at your shoulder and kind of talks you through it. There is an element of online training, there's an element of classroom training, which will require people to be out of the workplace for sometimes half a day, sometimes 1 day, sometimes more than that, depending on role. And the training is bespoke to everyone's role. So we've been doing a process called role analysis, which really is trying to match people's role to the training elements that they're going to need to be able to access the parts of the system that they need to do their job, because it is a very complex system. It's an intuitive system, but it still needs a significant amount of support to actually make sure you're using it to the best advantage possible. And so lots of work being done to prepare people for that, and the super users are a key element of that process. So in a previous incarnation, I was a super user for a different EPR implementation in the emergency department. So I was trained to a higher level. I was expected to support my colleagues, both in nursing, at the front desk, and medical staff on duty, in accessing various elements of the system and in doing their day-to-day work. And so we've, as Dermot mentioned, SET have recruited, I think it's over 950 people who are interested in being those super users, and they will have an extra element of training, an early element, to make sure that they're equipped to support people at go live and for the few weeks beyond that, while the system is bedding in. And that peer support is critically important. It really helps people feel confident. It helps them, it takes away some of the stress of the change, and the go live period in particular can be quite stressful. Everyone's under pressure in the NHS, and it does make a massive difference if you've got someone who can support you, who you recognise, respect, and know working with you. So as we go through the sequence of go lives, we'll be asking all of the other trusts to seek volunteers to be super users, to be part of that training and support element, which is so important for success. So lots of work going on around that. Training for South Eastern Trust will start in the summer and run for a number of weeks to make sure that all staff are trained to their best capability. And it will be, you know, in the programme, Sue Ports, the former training manager, her catchphrase was no training, no access, no joking, because your access rights will be dependent on having completed the accreditation for the training. So in order to do your work after go live, you will have to have turned up to training and been signed off. So we've talked a bit about the training and super user elements, and we talked a bit about how lives will change with the implementation of Encompass. And some of that will be about how people's roles change. And that's always a difficult conversation, isn't it? So there is a commitment that there will be no redundancies as a result of this. There will be the opportunity for new roles to be developed, and a lot of those new roles will be in supporting patients and service users, not just to access their care in a different way, but to help them navigate the system. And I think most people who work in the NHS right across the UK will agree that that's probably something that we don't do as well as we could. So this gives us an opportunity to actually give career advancement and patient-facing and service user-facing roles for people who possibly wouldn't have that opportunity. So we will be looking in depth at the roles that will be affected by the implementation of Encompass, and that work has already started. A number of work groups, specifically looking at workforce impacts, will be kicking off in the new year now and moving through, and that work will carry on beyond the first go live, and we'll have to adapt as the system develops and as the system adapts over the months and years when it's live, because this will fundamentally change how patients and service users access care and how we support them using our staff and our expertise. So lots of work to come on that in the next few months. Next slide, please. So as we said before, go live is only the beginning. It's the beginning of a long-term commitment to this system and a long-term commitment to taking advantage of the opportunities that it affords. And the fact that it's both health and social care in Northern Ireland means that it's extremely high profile from a European point of view. Apart from anything else, I think there's only one other European site that's gone live with the social care element, and nowhere in the UK so far. So everywhere else in the UK that's live with EPIC will be looking to us to see actually how is this done, how does it help with the integrated care system work. So lots of opportunities for us to demonstrate best practice. As Dermot mentioned, it really supports research because we will have a rich mine of data and a rich mine of standardized data to be able to access and develop research on. Information governance changes. There will be consistency around rules about access for various elements of the system, and I think there's a lot more work to be done on that, but it will give us a standardized approach to this. It will support incident reporting, and the data will support business intelligence, not just within the trusts, but also for regional planning and for that sort of resource allocation and really understanding how the system works. So lots of opportunities for us to take advantage of, lots of work to develop the direction of travel with this, and further elements, as Dermot mentioned. You know, some of the confidential inquiries have made recommendations about information sharing across private healthcare environments as well as the NHS, and that gives us a significant step change in a single version of truth for all patients and service users, no matter where they are, and allows clinicians to be able to access that information and support patients and service users wherever it is they might be, whether that's a home, whether it's in a care home, whether it's in a private healthcare facility, in a prison, or within the NHS. So a big step change in terms of how those information flows work and how we can improve care using that. Back to you, Dermot.
Okay, just to sum up, one question did come up in the chat about the patient portal. There will be a patient portal, and it will transform how we deliver care in Northern Ireland and how patients receive care. Patients will have access to their own records, their own information, but also be responsible for their own health possibly to a greater degree. It will provide a secure platform for virtual and IT delivered care, and it will be the front door of the health service going forward. So we're working through about the exact name that we will call that. There's been lots of different variations, but it will be the front door of the health service going forward, and everybody in Northern Ireland will have access to this app on their phone if they so wish. So with that, we probably have some time for some quick questions if people want to ask any.
Thanks, Dermot, Veronica, and Teresa, for your presentation today. I'm just picking up on a few from the chat that you might have missed. So we have a question from Philip McNeil about how this will join up with the integrated care system, and also from Tracy about, will this actually replace Paris, child health care and SOSCAR, or will it just interface?
I can.
Teresa, take that one.
Yeah, yes, for the most part, I think is the answer. Encompass is replacing SOSCAR, Paris, LSID, Maxims and eNISAT, with the caveat that some parts of SOSCAR and Paris are still likely to still be used after go live pending. This is particularly around the financial piece for adults and children's.
Okay, thank you.
That's pending on a development within the system, which will take some time to do.
Yes.
Okay. Oh, Dan has a question. What are the biggest challenges that the programme is working to overcome at the moment, and how you tackle them, and how can we all help?
Yeah, I think the biggest challenge is asking people to do a difficult task when they're already been asked to do lots of current difficult tasks. And when we talk about lots of difficult tasks, we sometimes talk in the IT space, thinking we're doing lots of implementations, we're doing labs, we're doing labs and radiology will happen seamlessly because they're exceptional programs run by exceptional people. And I've a lot, and they're replacing systems. I have no doubt about that. The trouble is there are lots of transformation going on in the clinical and social care spaces at the same time. And it's about people's ability to manage this amount of change. And where you get really strong leadership, and that's why I'll come back to Russian Coulter. She came to the UGM and just had a sort of road to Damascus transformation to say, look, we won't be able to do anything of substance in the future unless we provide an appropriate IT platform to manage our services. Well, some of the stresses on the system is that people find it difficult to manage the demand, find it difficult to understand the pressures, and we need this platform in. And once she'd understood that, she drove that forward in the Southeastern Trust with a will possessed, with a determination and her leadership. You could see everybody falling in behind her saying, this is a good thing to have, this is a good thing to do. And we see that as a very positive thing, because a successful implementation in the Southeastern Trust will be not a benefit for the Southeastern Trust, will be a benefit for all of Northern Ireland, because we'll have other people plugged into that programme learning how to do this.
Okay, we're getting a few more questions around the portal and how we're going to secure people's confidentiality, because there might be concerns about that. How will that be managed, Dermot?
Yeah, I'd probably have to defer to the technical team. It is managed, and it's managed across multiple jurisdictions. That being said, who hasn't been aware of somebody handing in their own personal password over, you know, at home? And I'll have to defer that to get a more detailed answer on that, because I just don't want to give an answer off the top of my head. I think the really important thing about the patient portal, it changes the dynamic of the social worker client relationship, and it changes the dynamic of the doctor patient relationship or the nurse patient relationship. And I personally believe that to be a good thing. I think healthcare is a bit patriarchal, and we have a habit of delivering onto people as opposed to being partners in care. And that's also a challenge for doctors or nurses, but it's also a challenge for patients being responsible for their care.
It's just worth noting that the portal is not new to us. So there are millions of people in the US in particular and globally who are live with this. And so it's a tried and tested solution. There's lots of things that we can learn from other sites that are live in terms of how the portal has been handled. So in Manchester, for instance, it was decided to do a kind of soft launch of the portal and just recruit people before going out to regional advertising for it. And the staff actually within the NHS are probably the best captive audience for that. So, you know, if every member of staff signs up to the patient portal and gets 3 of their friends to do it, or members of their family, all of a sudden you've got a huge number of people who actually have it on their phone, have access to it. And so there are various different ways that you can we can recruit people into it and publicise, but we have to be mindful that there is a bit of a digital divide. And in Manchester, there was a lot of work going on around digital accessibility through public libraries, etc. So we need to start thinking about how we can take it out to populations where they are digitally disadvantaged, and make sure that those people can access in the same way.
I think I would probably also add that sort of visibility and transparency of the record to the service user. That's something in social work we've been developing over many years. You know, making sure that we write that people understand what we're saying, and that the service user is included in that. I think with Encompass that will bring a greater weight, and also that transparency of our records to the other disciplines as well. I think there's also all of those discussions about confidentiality and sharing of information. Those are all taking place within our, you know, governance groups, and to make sure that the information is being protected and is only visible to those who are directly involved in the care. I mean, we have a concept called breaking the glass, and that will provide that assurance, and also indicating there's an audible reason for accessing that care information, or hidden altogether. So it's
I should say lots of services, when it started with cancer services, would have written to the patient and copied to the GP, and that changed the nature of the letters to make them more accessible and more intelligible, was probably a better thing. But there's no auditable trail about how that information is kept confidential once it leaves the post box. Whereas information on an IT trail, at least we can audit it and keep oversight of it.
Just to pick up on the accessibility piece, the DHCNI team have already made some outreach efforts to address that with other government departments as well. So we will be going into the libraries and doing pop-up sessions to help with that digital literacy people and do the outreach.
There's lots of information in America. Bizarrely, you wouldn't think on access by social determinants or social influencers of health, and you can see that the new divide is the IT literacy and IT access. If you can't afford a decent plan on your phone, you can't do at distance virtual consults, and so we need to be very conscious of that we provide equality of access.
On the accessibility, something that has come up with me in the past is around language barriers. And I know the Epic product has a number of languages built in. Have we assessed that they meet the needs of the Northern Irish demographic? And have we plans in place to fill that gap if there is one?
So I know there's some of the design groups were looking at that. There has been a review of the languages available, but I don't know what the situation is as regards the gaps. So we need to come back to you on that just to fill that one in. But I do know it's being looked at.
Yeah, and I think one of the biggest language gaps is that 27% of Northern Ireland have a reading age of 12. And we need to make sure that we use plain English, and we're not very good at that. I mean, there's no point in transferring medical jargon from paper notes to medical jargon on an electronic platform, because people will not understand it, and we need to train ourselves differently.
Another question on screening. Will call and recall be included?
Yeah, pretty timely. We are meeting the PHA and Epic to discuss screening programs on the 18th, which will be another extension of scope. There is the potential to do so, and there is a sort of a burning platform with the screening programs being of variable age, the IT supporting. We don't know the workings of that, because it may be better to be embedded within a national system, although the EPIC platform may be able to provide a better solution. So we'll have to have that discussion with the BHA to come up. Certainly with the 3 cancer ones, the cervical, breast, and colorectal. So there's no simple answer to that, but there is the capacity to do so. Sorry, there is the potential to do so. It's whether it's the right thing to do, and we need to have a discussion.
Yeah, as a service user, I would certainly on my portal want my recalls all to be coming through the one channel. I wouldn't, given the whole nature of scamming and all the rest of it, just putting that in there as a personal view.
No, I think that's just people within the system. It's very important we get this feedback now, because you will have greater insight, and there should be just one source of truth. And yeah.
Okay, any more questions? Any more? We'll circulate the slides from this. Again, thank you for your time, Veronica, Teresa and Dermot, and giving us the update. We'll look forward to hearing from you again in a couple of months' time. I know we're going to have more regular updates. Next month's session is about the learning management system. And again, that is a feeder for the Encompass programme as well, because we'll all be using that. So we'll definitely be looking forward to hearing from Yvonne Connolly on how that's progressing, because obviously that's a tool that we'll all need to access in the very near future. Again, thank you very much.
Could I thank everybody? There's a big number.
We had 155 people on at one time.
Yeah, so can I thank people who took given up of their time to listen to us? I hope you can get our passion that we're moving from preparing to actually doing. And thanks very much for the questions. They were really, really helpful.
Okay. Thanks very much, folks, and we'll see you all hopefully next month, if not before.